Hi, my name is Rachel Walters. I'm one of the principal occupational therapists working at the University Hospital of North Midlands. Following the amalgamation of our two local hospitals to form our trust, we observed differing treatment regimes between our therapy departments. One of these differences was the use of splints in the management of mallet finger deformities in the two OT hand departments. A mallet finger injury will occur when either continuity of the extensor tendon is lost or there is a bony avulsion of this tendon. This can occur after a forced flexion injury, crushed trauma or laceration, or as a result of a seemingly innocuous incident such as making a bed or pulling up a pair of socks. If the injury is left untreated, the terminal tendon length may be affected with an ongoing lag, and the finger can be caught, which may be painful, have poor aesthetics and result in deformity. Conservative management can involve various splint types: a prefabricated polythene splint called a stack splint, a padded aluminium splint which is cut to size, or a thermoplastic splint which is custom fabricated to fit the finger. A bespoke mallet splint is made using thermoplastic materials in a one-to-one appointment with an OT, as opposed to a prefabricated splint which can be issued in a clinic setting by a nurse. One of our sites within our trust were providing one-to-one appointments to fabricate a bespoke splint for all mallet finger injuries, whereas the other site would routinely provide prefabricated splints without any referral to OT at this point. In order to determine which was the best practice for these patients, we took our clinical question to the AHP CAP group at Keele University. We also consulted with the Pulver Taft unit at the Royal Derby Hospital to discuss their treatment choices and to formulate a clinical question. The following question was then asked. In a patient with a mallet finger deformity following acute finger extension injury or avulsion fracture, does a bespoke mallet splint improve outcomes and appearance and reduce complications compared to off-the-shelf splints? Our librarian used our search terms to look through the literature, and one systematic review and meta-analysis was found to answer our question. This was published in 2015 by Witherow et al. And suggested that there was an increased risk of skin complications with prefabricated splints, but otherwise there was no difference in treatment success. We therefore concluded that high-quality research is needed to evaluate the best conservative treatment options for mallet finger injuries, and there was no indication for us to change our current management of this injury on either sites of our trust. Further information about our CAT can be found on the Keele website.